All right. Time has passed 9 o'clock. Good morning, everybody, and thanks for joining this webinar in our Human Bytes AI Academy with the topic today of the future of breast cancer screening with AI, where we invited Anne-Kathrin from our partner ScreenPoint to give a short presentation here during the morning. Just before I'll hand it over to her, just a little bit about background about us in Human Bytes. We are a North European distributor of AI for healthcare and work within a number of different specialties, radiology, mammography, cardiology, acute care, digital pathology, radiotherapy, ophthalmology, and patient monitoring. So what we try to do is to cherry pick the best solutions around the world and bring them to the Nordic countries here and North Europe. Common for all of them is that we believe they are one of the best in the world, and they are regulatory approved. They have a solid evidence, and they are in clinical operation with a proven business case from sites across Europe. And the ambition with this Human Bytes AI Academy, where I think most of you have subscribed on our LinkedIn page, but is really to bring in new perspective and new inspiration for applied AI in healthcare. So how can it support a better patient outcome, health economic, workload reduction, and equality in healthcare? And here we are running, beside newsletters, also some webinars, and I just want to advertise a little bit for the upcoming ones, where we early May have one of the leading legal experts to talk about the responsibility and MDR and to consider when you procure and implement AI in clinical practice. We have our partner from Combinostic in Finland to talk about AI for neurological disorders, especially how you can have an integrated workflow for MRI and PET. And then later in May, we have our customer, Lucas from Haugeland in Bergen, to talk about how he have implemented AI for auto-contouring organs at risk. So 4 interesting one, and another one coming up in June is for fracture detection, how we have seen that has reduced the waiting time in emergency and to a large extent eliminated patient complaints. To the right, you have some of our historic webinars that you can find. We had digital pathology 2 days ago, AI and biomarkers, also talking about breast cancer with HER2-low and MSI and others, and prostate cancer with our customer Kai Villanova from Girona in Spain, and a few other. So if you have particular interest in any of those, sign up or contact us, and we'll be happy to do a one-to-one demonstration. The webinar here will be recorded and uploaded on LinkedIn page afterwards, so just for you all to know. So that was just a quick introduction about our role in Human Bytes, and over to one of our longest partner with the ScreenPoint Medical out of Netherlands. And Anne-Kathrin, maybe you'll just introduce yourself, and the floor is yours. You're muted, Anne-Kathrin. I think you're muted.
There I am.
That's better.
Yes, thank you, Ulrich, for the introduction, and also welcome from my side. Nice to see you all joining that early in the morning. So my role at ScreenPoint Medical is Medical Science Liaison, which means that I'm mainly involved in all these external validations that we do of our product. So as soon as we have a product, we of course constantly test and monitor how well it's actually working in a real world setting, and that's my role at ScreenPoint. And today I will focus on the clinical evidence that we have collected around Transpara. Let me quickly share my screen. Okay, so now you should see my title slide, right?
Yeah.
Okay, perfect. Today's webinar will be about the clinical evidence of Transpara, and I will present you an update on the latest clinical studies that tested Transpara's performance and robustness in breast cancer screening in different environments. Clinical evidence is a very important topic to ScreenPoint. We have 5 prospective clinical trials, either completed or still up and running in the US and in Europe. And we are also proud to say that we have the first RCT, randomized control trial in breast AI worldwide. Probably some of you have heard about it. It's the Maasai trial in Malmö. I will also talk about that one later, of course. We recently achieved another milestone. Transpara has evaluated more than 5 million 2D or 3D mammograms in real-life screening. We are constantly publishing, and by now we can refer to more than 30 peer-reviewed publications on Transpara in well-respected journals. Further, robustness and diversity are very important to us, and studies on Transpara demonstrated consistent results across 22 different countries by now and demographics. So taken together, we are proud to say that we are the breast AI solution with the most peer-reviewed publications. So let's have a quick look at how AI is integrated in the screening workflow. So maybe some of you haven't worked with AI yet and don't have such a clear image. So after the patient undergoes her mammogram, the 2D or 3D images will be analyzed by Transpara, and then the images and our results are delivered to you when you're reading. In contrast to a CAT workflow, what we would like is for you to know the Transpara result actually from the beginning of the read, so that you can use the AI information as additional support while reading the exam. Because what we are finding is that people who use Transpara in that manner can become more accurate and more consistent in their decision making, and also be more efficient. But as we go through that presentation, I think that becomes a bit more clear. Transpara is intended for use as a concurrent reading aid for physicians interpreting screening 2D and 3D mammograms to identify regions suspicious for breast cancer. And also, importantly, Transpara is FDA cleared and CE approved. So how does it actually look like? How does Transpara support you? Transpara decision support shows you the risk within an exam in 3 ways. It marks findings in the image. These are kind of CAT type findings that indicate whether it is a calcification or a mass, like here in this example on the top right. And then tags a region score to each finding, which indicates the level of suspiciousness. Transpara then categorizes an exam into elevated, intermediate, or low risk based on the highest region score that was found in an exam. So based on basically the most suspicious finding. And finally, you then receive the Transpara report that's shown here on the bottom right. This is a DICOM image within your hanging protocol that includes all the information at one glance. The findings with the associated region scores, and then on the right, the overall risk category, and also the highest region score is plotted on the right again. Here, closer look at the Transpara report. In this case, Transpara marked several findings, masses and calcs in both views. And on the right is then a summary displayed, the overall risk and the score of the most suspicious findings. So as I said, we have 3 risk categories: low, intermediate, elevated. Risk in the low risk category are 99.97% of the times negative. Exams that are labeled as intermediate risk have a chance of 6 in 1,000 to be malignant, and in the elevated category, 1 in 10 is a cancer. So this is where you should take a closer look. So here you see a very difficult case, high density, everything looks roughly the same. That's a typical case where Transpara could be of help. Transpara here correctly identified a suspicious lesion on the right MLO. So here's a full report of this case. Transpara assigned a region score of 77, categorized the exam as elevated risk, and the pathology indeed confirmed an invasive ductal cancer. So now that you have an idea of Transpara, I would like to share a selection of studies that have tested Transpara's performance in breast cancer screening and how it could help you on challenging cases. We know that breast density is a major challenge in mammography. Not only is density associated with cancer for women over 40, but it also drastically decreases sensitivity of mammography to as low as 50%. So this is a study from researchers from Norway, the group of Solveig Hovland. They have been able to demonstrate the value of Transpara in supporting earlier detection in women with dense breasts in a screening population. So what you see here in this graphic, these are 950 screen-detected cancers that are stratified across the 4 density categories according BI-RADS. And then the pink bar shows the percentage of cancers that were catched by Transpara, and in blue, the screen-detected cancers that were found by the first radiologist. And as you can see from the last 2 bars in D, Transpara could substantially increase the sensitivity for women with dense breasts, basically taking exam sensitivity from 63% to 81%. So this indicates that Transpara could help radiologists to read these high dense cases with more confidence. So this is a nice demonstration that Transpara helps you, especially with these high dense, difficult cases. There are the same analysis also on interval cancers, so cancers that by definition are missed by human reading in screening. We know that lack of reader sensitivity in screening mammograms unfortunately can sometimes lead to such interval cancers. And Transpara was here retrospectively applied to the screening mammograms of women who came later on with an interval cancer. And these cases were so not detected by the radiologist, but Transpara flagged importantly 48.6% of the interval cancers in the high dense breasts. So again, a nice demonstration how Transpara could help to detect earlier and to help in dense breasts. So let's say you are using Transpara as concurrent reading aid. So how is that going to affect your accuracy in screening? We have performed 3 reader studies, 1 with 2D and 2 with 3D mammography. Those studies included several sites, including 670 mammograms and a total of 46 radiologists originating from the US and from Europe participated. They all had different experience levels. And here you see our reader study RC graphs, visualizing the performance of the radiologists for evaluating a set of mammograms, ones with and ones without the help of Transpara. Their accuracy is expressed by the area under the curve. So in other words, a radiologist will be more accurate if the curve is near to the top left corner of the graph. And that's exactly what happened in all 3 reader studies. We see consistent results. So the radiologists become more accurate when reading with Transpara in all 3 reader studies, because the dark blue or solid black line in the right graph have all moved further up to the left. So the area under curve has increased in comparison to unaided sessions. So readers improved in sensitivity and specificity. Reader studies are, of course, conducted under experimental conditions, you could argue, with enriched data sets. So eventually it's not fully representative for a real-world screening situation. And of course, we have also looked into that. There was a recent study from Spain published last year, and they confirmed this observation in a real-world setting in clinical practice. So they implemented Transpara in their screening environment, and then they basically tested how it had affected their performance in comparison to a time period where they hadn't worked with Transpara yet. So in this study, they they compared 2 consecutive screening cohorts with each 12,000 exams. 12,000 read without Transpara, and then 12,000 exams read with Transpara. Importantly, roughly 50% were tomos and 50% mammos. And what we see is that when the radiologists use Transpara as reading aid, the cancer detection rate, here the left-hand graph, increased by 58% from 5.5 per thousand to 8.7 cancers per thousand screening mammograms, and that was also a significant increase. And that came with a slight increase in recall rate by 0.8%. We are often asked whether the improvement that you experience with Transpara depends on the experience of a reader. So is it eventually only the readers with low experience that have the most benefit? But actually, that's not what we saw. So we could conclude from reader studies that every radiologist, regardless of their experience, increased their accuracy. So there was no negative correlation between the increase in accuracy and the level in experience. In other words, everyone can benefit. So Transpara also helped very experienced radiologists, in fact. Another challenge where Transpara can help is facing the constantly increasing screening workload in times where we lack radiologists. And now I come to the Marseille trial that probably some of you are aware of. At Unilabs in Malmö, Transpara was tested in the worldwide first randomized controlled trial. And this study confirms that Transpara allows for safe and efficient workload reduction in screening. So let's walk through this step by step. About 100,000 women took part in this study. They were screened and then were randomly allocated to an AI-based workflow on the top, or to the usual double reading workflow without AI support. In the AI-based workflow, a triaging strategy was implemented, meaning only exams that Transpara had flagged as elevated risk were actually double read, while exams with low or intermediate risk were only read by one reader. Moreover, all radiologists in this AI-based workflow, they work with concurrent AI support. So they had access to the Transpara result. In the control arm, the standard double reading protocol was applied. All exams were read by two radiologists as usual without AI support. And on the right side, you see the results. So comparing the outcome of the study conditions demonstrated a significantly higher cancer detection when applying an AI-based triaging, although 90% of the screening exams were only read by one reader. And still, cancer detection rate increased by 28%, importantly with no effect on the recall rate. So recall rate stayed stable at 2%. And when you have 90% of your screening workload only read by one reader, this obviously means that you would save workload by 44% in this case. So we of course were very excited about these results. The team then recently also took a closer look at what kind of extra cancers did Transpara catch that were eventually not found in the double reading scenario. And they shared some interesting insights at the European Congress of Radiology last month. What they saw is that more invasive cancers were found when one reader was replaced by AI for the lower and intermediate risk cases, and all readers read with AI support. Moreover, Transpara helped detecting the rather small cancers, so T1 cancers up to 20 millimeters, while the double reading scenario catched rather the large cancers above 50 millimeters. So looking at different cancer types with AI, more invasive cancers were detected, and we expect more detailed information on this to be published at the end of this year. So the team is working on that. Then another prospective study that I would like to share with you is currently performed in a Spanish breast cancer screening program. This study shows what would happen if we skip human reading for low-risk cases completely. Importantly here again, screening is performed on 2D and 3D mammography. Roughly 50% was tomo. Exams labeled as low risk are excluded from human reading. That's roughly 67% of the screening volume, while exams with intermediate and elevated risk are again double read, and then also with Transpara as reading rate, and control whether such an implementation is safe and efficient. They are also having a control arm. So right now, all exams are additionally also read in this control arm where we do double reading as usual without AI support. And first results were also presented at ECR last month after inclusion of roughly 25,000 women. And the results indicate that the AI-based triaging strategy, so replacing human reading for low risk completely, still increased the cancer detection rate by 16%, probably just due to the fact that readers were reading with AI support. And then there was a slight increase in recall rate from 4.8 to 5.5%. So overall, taken together, a workload reduction of 67% with 16% cancer detection increase. And we expect final results after completion of the trial that probably in the second quarter of this year. So let's actually go to Denmark. The screening program in the capital region of Denmark was the first program that actually took the step and replaced one reader in their program for parts of the screening volume. Since November 21, cases at Transpara labeled as low risk are only read by one reader, while intermediate and elevated risk cases are still double read as usual with AI support. And so right now, Transpara replaces one reader for 70% of the screening workload, since roughly 70% of the screening population fall into this low risk category. It's the first time that AI is implemented in a national screening program, and initial results were presented at RSNA last year. And what they have seen since they have implemented this triaging strategy is a 34% workload reduction, a decrease in recall from 3.1% to 2.4%, and importantly, an increase in cancer detection from 6.9 to 8.3 per thousand. That's a 21.9% increase. I also would like to give you a brief outlook of what to come in the future. Another field we are entering is risk prediction. I would like to share one last study with you on that topic, also coming from our long-term research partners in Copenhagen. They actually built a risk model based on the Transpara score, mammographic density, and tissue texture. A risk model that is so purely based on image-based information, in contrast to the traditional risk model that you are probably familiar with, taking into account these three factors. They first trained an AI model combining these factors on a data set of roughly 40,000 screening exams. And then they tested their model on a screening cohort of 120,000 women attending biannual 2D screening. And for each mammogram, their image-based risk model calculated a risk score for developing cancer within 2 to 5 years. And results show that the combination of Transpara and texture information yields the most accurate prediction. So the 10% of women with the highest risk score based on this model accounted for 44% of interval cancers and 33.7% of long-term cancers. In other words, based on just the image information, by selecting the 10% women with the highest score when combining the Transpara exam score and the texture information, we can identify 36.5% of women that will develop cancer within the next 5 years. Transpara is constantly trained on new data and therefore constantly is raising its performance. Here's an overview of Transpara's improvement over the last years, combining several benchmarking studies. These are data sets from screening populations from the US, Germany, Sweden, Austria, Spain, the Netherlands, UK, and Italy. So 8 quite diverse data sets. When you take a look at the right graph, the yellow dots are 115 individual radiologists that rated these data sets. and they see their performance regarding sensitivity and specificity. The dashed black line indicates the average performance of the radiologists, and the blue and purple you see Transpara's performance of the version of Transpara in 2019. That's the blue line, and the purple one is the newest version of Transpara. And the take-home message here is that Transpara continuously improved, while in 2019, Transpara performed as good as roughly the top 50% of radiologists. The newest version of Transpara by now performs as good as the top 10% of radiologists. So seeing these steep increases shows the great potential of Transpara and where it's still going to. And I would like to close with an overview of where in Europe Transpara is used in clinical practice today already. Countries marked in dark use Transpara for replacing a second reader, partially in screening. There are several sites in Sweden, Denmark, and Spain. And in many more countries across Europe, Transpara is used as concurrent reading aid in screening already. Yeah, with that, I would like to thank you for your attention and encourage you to raise any questions you might have.
Yeah, thank you, Anne-Kathrin, and please do ask a question in the chat if anyone for Anne-Kathrin, and while we see if things will come in, then allow me for a few questions here. One thing we have deployed it both in the region capital Copenhagen of Denmark and the region north in Denmark with similar results. But one thing we also saw is that the one that where Transpara judged false negative is where you do not have priors in, where you don't have the access to longitudinal tracking. How do you see that develop in the coming year here for your solution?
The implementation of priors.
Yeah, and the potential effect of priors.
Yeah, so implementation of temporal comparison is in our pipeline and will come. And we indeed also expect an improvement in our algorithms when implementing priors. That's of course a criticism that we have heard often, because readers in their clinical practice they used to compare obviously to previous exams, and that's something that AI hasn't been able to deliver yet, but it's certainly something that's coming very soon, I may say already. And so that's the next step we are excited about to also deliver.
Yeah, thank you. Because what we at least saw in the deployment here in Denmark is that the ones that the AI did not catch, but the radiologists catched, were the one where human had access to priors, and adding that to the solution will probably help the sensitivity even further. Another now. This is probably one of the one where we have the strongest evidence across the world, especially from Europe and the Nordic, and also in the top of the evidence pyramid with the real world data and RCT, etc. So one could also consider to fully replace the first reader. But how do you see that? Because now we have that with the 90% is at least safe. But fully replacing a reader, will that have any impact on the consensus rate or the recall rate as you see it?
So based on our studies, what we highly recommend is this combination of human reading and AI going hand in hand. That's where we expect the highest benefit, because there are still also cases that Transpara missed, but that are catched by the readers. While there are these difficult cases, high dense cases, very small cancers, subtle changes, that's where Transpara can help you, where the human eyes just has difficulties to catch these in mammography, or also where mammography is just also a difficult tool regarding sensitivity. So based on our studies, we feel confident to say that the combination of human reading and AI is for now the way to go. And I think the RCT is the biggest piece of evidence that that gives you the confidence to safely implement that.
Yeah, so the additional saving you get for not replacing the last 10%, you kind of lose on consensus and recall rate and detection rate. So it's a trade-off, and I guess that's why you recommend for the really high risk the continuous double reading. And I think that was actually the question for Kiki here also. Let me know, Kiki, if that was not the complete answer. The other one is from Maiken here asking. I guess it's a little bit a question to the robustness or generalizability of the AI. Can it work in a local setting, or do you see any difference in performance whether you deploy in Denmark, Sweden, Norway, and Spain?
If we well, I think what the studies have shown is that the results are all very close together. So that was obviously something we were also interested in, is that eventually, how robust is Transpara, right, across different populations? Does it matter if I employ in Scandinavia versus in the south of Europe? And we see consistent results. So in that sense, we are confident to say that Transpara is quite robust across different populations and diverse screening populations.
And that's also what we have seen in the deployment we made now 2 places in Denmark, that the results are similar. But I guess at least from our point of view, if you have the desire to process some few cases and just test it out, we can do that both retrospective, but what we actually recommend is that you deploy it in a clinical setting, so you get as close to the reality as possible, and then in the first few months you may continue to do some quality control. We have also seen some customers deploy differently, that they only start with the 50% low risk and gradually increasing to 70% and now getting up to the 90%. So if you want a little bit of safety, that's an adjustment we can easily make, so you can continue to have double reading on higher risk cases based on your own thresholds. Any other questions here from the audience? Otherwise, I think quite a few studies documenting quite impressive improvement in cancer detection rate with especially the small invasive cancer and in situ, so allowing for earlier and more effective treatment. So that's something that needs to go into the business case, obviously, and for downstream treatment. And then the potential related to this for women with dense breast and also the interval cancers here. So quite a good potential, and looking forward to the coming year here with the further improvement on the algorithm and the priors, etc. Any final remarks from you, Anne-Kathrin, here before we wrap up?
Yeah, only maybe that all the studies that I presented today are published, so you can access them online. Also through our website, you could request the papers if you don't have access to journals yourself. We're happy to share the papers with you to read up later on.
Yeah, please reach out to Anne-Kathrin, ScreenPoint, or us in Human Bytes, and we'll be happy to share. And if you want a local session where we get a little bit more into a demo and seeing the tool itself, also reach out and we can easily do that. But on that note, as mentioned, the session is recorded and will be uploaded. And thank you all for joining, and have a good day. Thank you. Bye.
Thank you.
Thank you.